This is the Emergency Medical Minute, sponsored by Health One.
So I just wanted to kind of give you my take on that, a little context about why it matters. So when we get our BVM bags out of the our resuscitation bags, I'll call them. When we get them out, they have this little expiratory port on the back, and I think we all were kind of taught that when we hook this up to oxygen and begin assisting the patient breathing, that they're basically getting the oxygen that's coming in from the wall source. But in fact, what happens with these valves is the patient can just entrain as much air through this exhalation port as they can generate pressure. So in a spontaneously breathing patient, like if we're assisting their ventilations, for example, they're probably just getting room air. So they're largely just entraining room air through here. So that is one reason why the PEEP valve is beneficial to put on in these resuscitation bags in every case. Additionally, most of the patients who we're bagging are pretty critically ill. So whether they have pneumonia or sepsis or a COPD exacerbation or an overdose or trauma or what have you, so they have very little what we call functional residual capacity. So once they become apneic, say we give them rocuronium or succinylcholine or a muscle relaxer for their RSI, they very rapidly will desaturate. And we've all been in those stressful situations where the patient's rapidly desaturating as we're trying to intubate them. What we should do in all these cases is try to maximize their pre-oxygenation by using one of these PEEP valves and some positive pressure ventilation. So what the PEEP valve does is we can just put it, actually it goes on, I think I have to take this part off, this part on, like this. When we have our PEEP valve on like this and we screw it in, then we can dial in our PEEP, and typically we'll start with about 5 centimeters of water pressure of PEEP, and then we can bag that patient. What that does is, assuming we have a nice tight seal with the mask, when the patient is exhaling within that closed system, they're getting the PEEP, which, if you recall, PEEP and CPAP are really the same thing. That positive end-expiratory pressure is really functionally the same thing as being on 5 of CPAP. So we call it CPAP when they're on a circuit that's delivering that pressure. If we're just using a valve on a mask, we're going to refer to it as PEEP. But really, it's the same thing. So the advantage there is it helps recruit all their little collapsed alveoli. So at the end of exhalation, picture all these little alveoli kind of coming together and sticking like little wet pieces of cellophane. So when they then take another breath or we bag in another breath, we have to generate that additional positive pressure to pop open all those little alveoli and recruit them again. By maintaining that, say, 5 centimeters of water pressure at the end of exhalation that PEEP valve allows, those alveoli never collapse. So they're open, and then they may decrease in volume, but they're not fully collapsing. Therefore, the work of breathing is getting increasingly easier as we're holding and maintaining those alveoli open. A lot of the work of breathing, when you look at a COPD or you look at a CHF or someone with pneumonia or sepsis, is the terrible work of breathing of overcoming all those little collapsed alveoli which are stuck together. So that's the second reason for putting these valves on. The first being to prevent them from just inhaling room air oxygen. This is now truly a closed circuit. The second being using that PEEP, that positive end expiratory pressure, to maintain all these alveoli open throughout their respiratory cycle. So PEEP valves, very important. There is no situation in our ER where we're using one of these resuscitation bags where we don't want this on there. So for example, when we're getting ready for a procedural sedation and we're getting the BVM out in anticipation of RT coming down, or we're helping get these patients ready, maybe RT is stuck and we're waiting for RT to respond, we need these PEEP valves every time. Does that make sense? Any questions about that? I know that's a lot of information and not something that we're necessarily used to doing ourselves. Let's have a good shift. Thanks, guys.
We are on a quest to provide the world with free medical education. Please help us out by rating us on iTunes, following us on social media, and subscribing to our newsletter at emergencymedicalminute.com.